So I'm talking about how to develop effective and tolerable combinations. If you actually think about the cancers that we have a reasonable cure rate in, childhood leukemias, testicular cancers, some of the lymphomas, and even early stage breast cancer, those are all improved the outcomes through developing effective combinations of drugs. Because most cancers have multiple mutations, they rapidly develop resistance mechanisms to any one individual therapy, so combinations are essential if you really want to improve the cure rate, which I think is the ultimate goal. And in order to do that, you've actually got to understand how to create tolerable combinations, because most drugs, when you try and put them together, if you've already dosed one drug to its highest maximum tolerated dose, it can be very difficult to add in even a normally tolerated additional drug. The two together can often result in additive side effects that mean that patients won't stay on them for long periods of time. So one of the topics I'm talking about is the fact that you don't necessarily need to dose both drugs continuously in order to get an effective regimen. That in fact we should be testing intermittent schedules of combination therapies in order to get a tolerable regimen. And in fact, if you look at the hitting of the pathway that you want to achieve with the individual drugs, you can sometimes do that more effectively by actually dosing it intermittently. So I kind of hit and run on the cancer and allow the normal tissue to recover. And in fact, we've been doing this for decades already with most chemotherapies, but we haven't necessarily applied that same thinking to the era of targeted therapies. So I'll give a couple of examples of ways in which we can do that and the regimens that are coming out. When people started looking at the targeted therapies and looked in vitro and then in vivo models, because they have a better therapeutic index than many chemotherapies, you could get tolerable continuous monotherapy regimens. And in fact, if you look at examples like the epidermal growth factor receptor inhibitors, patients can stay on those drugs for many months and years as monotherapies. But as I've said, you're unlikely to achieve cure in any but a really tiny fraction of patients with a monotherapy, even an effective one against a driver oncogene, because most patients have many mutations in their cancer at the start, and what you do is you apply a clonal selection pressure, and the resistance, those clones, even if they're in a very small allelic fraction at the start of therapy, will grow out over time and become the resistant mutation that will drive progression. So the best way of trying to look at that is try and either prevent resistance, and I think what we're going to find is you're going to move well-tolerated combination regimens up front. To do that, you need be able to put these 2 or 3 drugs together. So I think it's only really in the context of trying to solve that problem that people are starting to go back and say, well, actually, do we really need to have continuous exposure to a drug in order to affect anti-tumour cell kill? And the answer is you don't. Immunotherapies are a paradigm changer, particularly the PD-1, PD-L1 antibodies. But actually the biggest unmet need we're going to have very shortly is all the patients that don't respond to a PD-1 or PD-L1 antibody, and how do you make the next step forward? And as you rightly say, the next step forward will be through combinations. And again, what we need to understand is what additional mechanisms are required to enable checkpoint inhibitors to work in those patients who don't currently respond to monotherapy checkpoint inhibitors. So there's a lot of work we need to do there about understanding what those mechanisms are, selecting the right patients for the particular drug or the particular combination of drugs, and then working out, again, tolerable regimens to enable those to go forward. So I'm going to talk about a dual TORC1/2 inhibitor, AZD2014 or vistasertib, which we're developing in ER-positive breast cancer in the combination with fulvestrant. So ER-positive breast cancer is obviously driven by signalling through the estrogen receptor, and that's a lineage marker that's important throughout the lifetime of the cancer. So it's important that you have a really good hormonal backbone. But we know that signalling through the PI3 kinase pathway can generate endocrine resistance, and so looking at that combination. And we've compared intermittent and continuous dosing regimens of vistasertib on the background of fulvestrant. And then we're looking, having developed a tolerable doublet combination, to then move to a triplet combination with the CDK4/6 inhibitors. Again, I think the important thing to look at is the long-term discontinuation rate due to adverse events and the maintenance of anti-tumour activity over weeks rather than just looking at an initial response rate. So that's one example I'm going to talk about. The second is looking at a class of agents called DNA damage response inhibitors. So we already have a PARP inhibitor, Lynparza, which is approved on the market in ovarian cancer. But actually, again, if we want to target the DNA damage response effectively, preclinical data that we have suggests that combinations of cell cycle pathway inhibitors such as a WEE1 inhibitor together with the DNA damage response inhibitor like a PARP inhibitor prove to be very effective. And again, looking at the regimens of those and the schedule in order to avoid intolerable side effects on bone marrow or GI side effects are really important. If you really understand which patients have tumours that are driven by a particular pathway, you can tailor the combination to the right patient and still drive a difference between the sensitivity of the tumour and the sensitivity of the normal tissues. So we see that's possible in, again, tumours like the EGFR-driven tumours with combinations of EGFR and MET inhibitors. It's clearly possible in ER-positive breast cancer, shown chronically tolerable regimens. And with the DNA damage response inhibitors, actually, if you select the right patients that have, for example, a BRCA mutation, there's actually much better therapeutic index for those compounds than there is for traditional chemotherapy. And so you can stay on the drugs for longer. We've had people staying on olaparib for many years, in fact. So that's a better tolerated backbone then to add in another therapy and produce a long-term tolerable regimen. So I don't think it's necessarily true to say that by introducing new drugs, you're going to worsen the side effect profile. I think you have to understand which patients, how to use the combination effectively, and in which situations it's likely to be better than currently available therapy. I think the future is very optimistic. This is a golden age for cancer drug discovery and development. As I said, I think the immunotherapies are going to be changing the paradigm, but let's not forget that there are multiple other mechanisms. What we need to learn is how we put those together so we can actually improve the cure rate for patients with cancer.